And we will continue with our next talk. It's not going to be a live case, it's a Medtronic-sponsored session. And you're going to talk to us about the latest experience with chronic subdural hemorrhage treatment. I expect a lot of discussion after this topic. Yes. So we are very excited to hear about it.
Thank you, Medtronic, for the kindly invitation. I will do the speech about the probably most hottest topic in the last 2 years, about the chronic subdural hematoma. Yes. Can you put my slides? Okay, thank you. So this is the hottest topic of the past 2 years regarding the American Neurosurgical Society. Chronic subdural hematoma become the most common neurosurgical condition by 2030. Regarding the most common reason is the more and more people use the antiplatelet therapy and the anti-aggregation. The increase of during these 10 years, the incidence of chronic subdural hematoma range from 1.7 to 20.6 per 1,000 hundreds inhibited, and mainly affected the elderly peoples. But the chronic subdural hematoma is a story of controversials and debate. What kind of surgery, incidence, indication for surgery, timing for surgery, surgical methods. Do we need to do craniotomy, twist drill, or hole drill? Number of burr holes, location of the burr holes, irrigation or only drainage, location of the drainage, subdural or subgaleal, duration of drainage, membranectomy, and now we have a new chance to treat with middle meningeal artery embolization. Burr hole versus twisted drill, or craniotomy versus small craniotomy. The conclusion of the lot of papers there was no significant difference in mortality in these papers. But we have one clear message that drainage reduces recurrence. Subdural drainage for approximately 48 hours decreased the recurrence rate between the 24 to 9% and the 6 months mortality from 80 to 9.6%. So we should use drainage. About the position of the drainage, did we need to put subdural or subgaleal? There is a lot of discussion about that, but in the end, we don't find a serious difference between the position of the drainage. Subdural hematoma after the brilliant surgical procedure, we have a remnant recurrence after the surgery between 10 to above 20% of recurrence. For this reason, we should treat or to do something for decrease the recurrence rate after the surgery. The answer is probably middle meningeal artery embolization. We have a couple of meta-analyses of a lot of patients and a lot of study. They show us the recurrence rate more than 10% after the surgery. And the recurrence after the surgery plus embolization is 2.3%. It is more than double. In conclusion, corticosteroids are associated with reducing recurrence, but also increase the mortality. Drain reduce the risk of recurrence, but position of drain didn't not influence recurrence. And middle meningeal artery embolization is promising treatment. In the embolized trial that it's already finished and published, we show that the group with onyx and surgery, we have a recurrence rate around 4%, and surgical group only, it is more than 11% of recurrence rate. That is mean with surgery plus embolization, we have a half reducing of the recurrence rate. During the embolization, of course, we should be attent on the dangerous anastomosis, especially about the branch to the orbital branch and the posterior branch with the blood supply for the seventh nerve. This is the things that we should overview during the embolization. European protocol for the subdural hematoma, it is our first line of treatment. Patient with, of course, with recurrence. Patient contraindicated for the surgical treatment, that is mean the patient with anticoagulant or antiplatelet therapy. For the surgical protocol, it is we do the surgery for the chronic subdural hematoma within more than 1 centimeter, even if it's asymptomatic. Midline shift more than 5 millimeters, and subdural hematoma within less than 1 centimeter, but symptomatic. The patient who is on antiplatelet therapy, of course, is suitable for endovascular procedure. I will show a couple of cases. This is the 76-year-old male, had injury before 1 month ago. Since 2 days, left side hemiplegia. It is glaucoma score 15 point. This is the initial CT. Single blue hole, we decide to treat with single blue hole and subdural drainage for 48 hours. 1 month post-op with good clinical recovering in that moment, but 1 month later, he will come with left side hemiplegia. Control CT shows recurrence of the chronic subdural hematoma. During the procedure, we try to go distal that is possible to do embolization. 1 month post-op with good recovering of the patient. The second case is 76-year-old male, headache, and he presents with headache, vomiting, left side hemiparesis. Comorbidity, it's with high blood pressure and arterial fibrillation. We don't have data about the taking of the anti-aggregation of the patient. This is the initial imaging with chronic and subacute subdural hematoma and brain shift. During that, we decide to do 1-stage surgery and embolization. We choose brew hole and drainage for 48 hours. This is the baseline angiography. We see the stenosis of the right carotid artery. It is more than around 50%. And for this reason, of course, we do with the liquid embolic distal that is possible to embolize. And we put the microcatheter this dangerous anastomosis that I already mentioned. The goal was to stabilize the chronic subdural hematoma and allow us to prepare patient for the with antiplatelet for the further carotid stenting. Follow-up CT 1 month later with good recovery of the patient. Here is the video of CT. If it's not going, okay. In conclusion, chronic subdural hematoma will keep increasing in our daily practice. MMA embolization with surgery reduce recurrence and helps for the high-risk patient. Our job is simple: select well, treat safely, and follow outcome. Thank you.
Excellent presentation. Where do you see the barriers for adoption?
For
where do you see the barriers for this becoming standard practice in every center?
I already mentioned that the patient who is suitable for the surgery, it's the brain shift more than 5 millimeters, and especially the patient with severe neurological deficit.
What I meant is the evidence will come, the randomized studies will need to be done, but it is a huge amount of patients.
Yeah.
So I wonder, will we be managing so many patients? And also, is there barriers? Is there a lot of training need for that?
No.
How do you see this going to expand? And what are the problems for a wider expansion?
In my mind, the only we don't need, because it is easy procedure and nothing's more. But the main problem in my mind is the topic between the neuroradiologist and neurosurgeons. If they refer more and more patients for the endovascular treatment, probably the percentage of the treated patients will go extremely high. So this is my opinion, actually.
Any other questions?
Then we need more centers than for thrombectomy. Anyways, MMA seems to be a magical artery. Now we are starting to embolize for the headaches and the migraines and whatever. We'll see that. One question for you practically: when do you do the both sides, the both MMA? What is your indication for the both side treatment?
Of course, when we have both sides chronic subdural hematoma, of course.
Not for the one-sided?
No.
Okay.
And what is the limit where you would still do surgery? Is it from the midline shift that is above 1.5, or when would or 1 centimeter, and in children 0.5, when would you still operate?
For
in addition,
me,
probably.
the most important thing is neurological deficit, because oftenly I see the patient with brain shift for more than 1 centimeter without any neurological deficit. So if it's the patient older, I would prefer to do embolization, nothing more.
Perfect.
Thank
you very much. Welcome. Yeah.
Yes, it took 5 minutes, 10 minutes, nothing more. It is, yes, in one session. Especially when you open the bottle of liquid embolics, you can use for the both sides.
Do you believe that the coil should be better, easier?
Yes, wonderful question, because the DMSO is painful for the patient. We used to use conscious sedation, but it's still, you see the movement of the patient, and probably only with the coils you will avoid conscious sedation or something, or general anesthesia. So I believe that it's possible to do with the coils. Why not?
I think during the anesthesia depends what is the level of consciousness of the patient itself, because sometimes they're not very cooperative. But the industry is pushing us, no, the codes are better. No, I think it doesn't matter what you will block completely, the vessel will work. But just asking what your opinion.
The theory is that you should go distal to this painting branch of the middle meningeal artery. The goal is to reach this zone that you will do the embolization. But in the beginning of the question, it was my answer will be it depends about the experience of the anesthesiologist. If you have a strong anesthesiologist with you, he will be able to manage without general anesthesia. If it's young anesthesiologist, he will prefer to do general anesthesia, and that's it.
Also in the meta-analysis cited, they say there is no big difference between distal penetration and proximal.
But it's still debate. This is it will be still felt about the discussion. Yeah.
Okay, there are no more questions. Thank you. We'll go
Thank
to
you.
our next speaker. Thank you very much.